Welcome to Open Classroom, the Brown School's digital forum for community and conversation. We are so glad that you're here. My name is Laurie McConnell. I'm communications coordinator here at the Brown School. And today we continue this 6-part series of Open Classroom webinars, building a transformative 21st century research agenda. But before we get to that, I want to quickly do a little bit of housekeeping. We're using a webinar format, which means that we don't get to see or hear you, but we would love to know your thoughts, your questions. Please feel free to post them in the chat at any time, and we'll have folks collect those questions and comments and use them at the Q&A session at the end of our program. Also, we're going to be sharing a survey with you at the end of this program, so we hope you don't have to leave us early. We are incredibly interested in your thoughts on how to make this series even better, so we will post a link to that survey in the chat towards the end of the program and give you an opportunity to fill it out. It's very quick, just a few questions. I also want to let you know about some future Open Classroom programs that you can still get registered for. This coming Tuesday, September 27th, we have our iChat speaker series with economic strengthening interventions among caregivers in sub-Saharan Africa. Then next Thursday, that's September 29th, we are back with this series, and we have our own Dr. McKay along with her wonderful co-presenter who will discuss collaborative research methods to elevate the voices of youth, adult caregivers, and providers in child and family-focused studies. And on Wednesday, I know that's unusual, we have an Open Classroom Wednesday on October 5th. We're going to discuss the Indian Child Welfare Act as it faces scrutiny in the Supreme Court this fall. So I will put a link to our Open Classroom page in the chat in just a moment so that you can get registered for any upcoming webinars. They're always fascinating, they are always free, and they're always better when you're here with us. So right now we will get to the main event. I will introduce you to the wonderful people that you're going to see on your screen during this webinar. First, we have Cynthia Williams, Assistant Dean for Community Partnerships here at the Brown School. Cynthia will help us with some fantastic questions and answers, along with Nicholas Asher, who's a Program and Project Assistant at Washington University, as well as an MSW and MSP candidate. And now to Dr. Mary McKay, who's President of AASWSW and Vice Provost of Interdisciplinary Initiatives here at Washington University. Mary, I'm going to let you sort of talk about the genesis of this series, introduce our special guest from Casey Family Programs, and welcome our brilliant presenter for today.
Wonderful. Thank you, Lori. Thank you so much for all that you do. And we so appreciate this collaboration. So hello, everyone. I'm Mary McKay, and I have 3 sets of participants to welcome here. Those of you that have joined us live as we go forth with this webinar, those of you that I can't see right now on YouTube, but I know that you're there, and we so appreciate you joining us via the web. And also those that could not attend, but that we will send you this recording. So thank you so much for being with us today. So what is this series about? We are engaged in an incredible collaboration with a set of foundations that really have set forth a bold agenda for how do we support children and their families with research for the 21st century. How is it that we truly actually value and center collaboration, particularly collaboration with people with lived experience? So the foundations have taken the lead. They have organized a set of collaborators, and the American Academy of Social Work and Social Welfare are one of the organizations that have been key in the steering committee and in the kind of driving of the agenda. So I feel really privileged to have Peter Pecora here, who is a program official with one of our foundation partners, but also who is an Academy Fellow. And so you're playing double duty here, Peter, but if you could tell us a moment about what the 21st century research agenda is about, and then I'll introduce our speakers.
Happy to do that, and thank you for the opportunity here. I'll be very brief, but provide a little background. Since May of 2019, a diverse group of researchers, policy experts, diversity, equity, and inclusion experts, and people with lived expertise with the child welfare system have been working together to identify the highest priority research gaps that, if addressed, would enhance the development really of a a research agenda to inform what a 21st century approach to child and family services might look like. So what began as a partnership between Casey Family Programs, the Annie E. Casey Foundation, and the William T. Grant Foundation has evolved into a wider coalition of philanthropic and federal organizations, other national organizations like the Academy. And we've been buoyed by a participation from individuals with life experience with child welfare all the way through the process. We, as a sort of a project team, as a coalition, believe that timely and targeted research should address the most critical issues facing our field, and that research, if it's done well and disseminated well, can really support some of the innovative policy change and changes in funding that I think we all know we need. Currently, the project team is seeking research funding for the highest priority research gaps, and we've been making presentations to a wide range of federal, foundation, state, and large county organizations who might fund the research for that. And we're also trying to make presentations to help transform the research community, the researchers, and how researchers see their role with the people that they work with in a context of a social justice oriented approach to research. We're trying to improve the field of research at the same time as we're all helping to reform child welfare. And we think that research can make a big difference in that area. We think that stakeholder involvement, guidance, and funding is going to help researchers focus on the most critical areas. And to do that, we need participation by community leaders and people with lived expertise in the development of that research agenda, because that's what lays the groundwork for an effective collaboration. So Geetha and Cynthia today are going to be speaking to a very key issue that is addressed in part and explained in the National Research Agenda documents and the reports, and that is speaking to issue of why we need better collaborative work between mental health and child welfare, because so many children and their parents are not able to access high quality mental health services when they need them. And this inadequate access and this lack of quality in some of the services because of staff turnover or inadequate training are really hampering efforts to keep families safely together. And so this is an issue, again, that we've highlighted in the National Research Agenda for a 21st Century Child Welfare System in our reports. And we very much thank Geetha and Cynthia for their time today. So I'll turn it back to you, Laura.
Thank you, Peter. So I so appreciate the support and the collaboration. And so I am going to turn it over to folks that we want to hear from them about. Geetha, your important research. So Geetha, you are an associate professor within the CUNY system in New York City, Hunter College, or the Silberman School of Social Work to be specific. And I have to be very transparent. I have watched Geetha grow in this field as an implementation scientist. She now is a tenured faculty member and an associate dean, and really influential in the research that happens in your school and then across the field of children's mental health. And so Geetha, you're going to talk from your vantage point of a study that focused on families, in a part of the child welfare system. And you're going to have, I hope, a rich conversation with our colleague Cynthia Williams, who is the Director of Community Partnerships here at Washington University at the Brown School. But what I also learned in our run through was she was also a foster parent herself, trained foster parents. And so what we hope to do is see some of the best science that can happen, that could come up with new solutions to improve children and families' lives, but also the collaboration and the feedback that one could receive from somebody's experiences as Ms. Williams. And so with that, I want to say thank you. And those of you that are live with us, thank you, Nicholas, for putting in the executive summary for the 21st Century Research Agenda. If you're on YouTube, you'll get this right after our webinar. So with that, Geetha and Cynthia, please take it away, and we'll come back at the end.
Okay. So I wanted to talk a little bit about my study. It's called Developing and Maintaining Partnerships for Implementation Child Welfare Services. I want to acknowledge that I could not have done this alone. Received a lot of generous funding from the National Mental Health. And in addition to a number of individuals, I've also included here Dr. McKay, as well as Cynthia Williams for their help in helping me prep for this presentation and giving me some feedback that I've helped to incorporate as well. So I want to first ground this presentation in my own lived experience. In addition to being an academic, I have also been a provider, a social work provider in New York City. I first worked in therapeutic foster care in New York, and then I also worked in a psychiatric emergency room and outpatient mental health clinic, also in New York City. So the issues that I'll be talking about around families involved in child welfare services, as well as the experience of providers, are really close to my heart and is what really spurred on this research and what interests me in continuing moving forward. So my population of interest is really those families that are involved in child welfare services, specifically the large majority of families whose children are not removed from the home following an investigation. They actually represent the majority of families involved in child welfare services. What we know about them is their children tend to have disproportionately high rates of behavior difficulties, which can then place these youth at increased risk for maltreatment. What we also know from the research is that these families are less likely to access mental health services than youth in foster care or children not involved in the child welfare system. And this is due to a number of different reasons. Families, particularly those involved with child welfare services, have a number of competing priorities that may involve mandated services. They often don't have time, transportation, or childcare available to support making appointments. Many have stigma towards mental health, as well as prior negative experiences with mental health services. They struggle with a number of stressors, but also importantly, there's a systemic issue where there is not enough mental health providers, child mental health providers, to meet the need. And so what often happens is families are on waiting lists if they choose to stay on the waiting list at all. So what guided my study and the purpose of why I do what I do is really ultimately to increase the access to effective services to address child behavior difficulties for families involved in the child welfare system. So to that end, when we talk about effective services, what the research tells us is behavioral parent training. This is a group of different types of interventions that really target a bunch of different family processes, as well as communication and conflict. And what we know from a number of these interventions that fall under this umbrella term is that they're effective in reducing child behavior difficulties. They're also effective in reducing caregiver stress and depression. They can enhance parenting skills. However, typically they're often delivered in mental health settings. One particular intervention that I know very well and that Dr. McKay and I have worked on for a number of years is the 4 R's and 2 S's for Strengthening Families program. This program is a multiple family group service delivery model, meaning that we bring about 6 to 8 families together for weekly group meetings over 16 weeks. At each meeting, we address some of those logistical barriers I talked about, where we provide childcare, a transportation reimbursement, and a meal, and also provide content that targets these concrete and perceptual obstacles to engagement, but that also address those family processes that we spoke about, as well as improving social support. So you may be asking, what are the 4 R's and 2 S's? And so here's a table that really explicates that in more detail. So the 4 R's really refer to rules, responsibilities, relationships, and respectful communication. And these are what behavioral parent training typically focuses on, those family processes that are involved in reducing child behavioral difficulties. Additionally, we focus on 2 S's, stress and social support. These factors have been known to influence the ability for families, particularly those impacted by poverty, to engage in service use. So as a result, the 4Rs and 2Ss has content that addresses each of these core concepts within its 16-week curriculum. So as I talked about before, many families, particularly those impacted by child welfare services, often don't engage in child mental health services. And so the idea that maybe we could offer behavioral parent training outside of mental health services beyond clinic walls. And so one particular setting that might be effective and to increase access is within child welfare services themselves, where families are already receiving services to prevent out-of-home placement. However, what the research also tells us is there's a number of challenges with actually implementing effective new services in child welfare, particularly for mental health treatment approaches. The people that work there, the caseworkers, often don't have advanced mental health training, as well as there usually isn't any additional psychiatric support. We know that caseworkers have very specific roles when they work in preventive services that may conflict with some of the strategies used with delivering some of these effective services. They often struggle with really heavy workloads, as well as extreme client needs like their parents' mental health, family disorganization, that often makes them have to react in crisis often, and that can really impact the ability to deliver effective services. We also know that there are maybe scope of practice regulations that may limit what caseworkers are allowed to do within their role. Funding also plays a big role in terms of what services can be provided through child welfare. And then there's a system culture that is very different often from a lot of the strength-based, family-centered approaches. And I'll talk a little bit about that as we get through the presentation. On top of that, we had these engagement challenges, the logistical barriers, perceptual barriers that I alluded to before. But really important in child welfare, particularly for families involved in child welfare services, is this involuntary status. So even though families may be technically voluntarily seeking preventive services, it's usually at the fear of having their children removed. So they're not traditionally voluntary in that respect. And so this may also play a role in engagement. So as a reminder, the whole purpose of this was really to increase access to effective services to address child behavioral difficulties involved in child welfare, for families involved in the child welfare system. So my study focused on how can we implement effective services in child welfare settings. So to think about how we could implement it, I looked to this strategy called task shifting, which has been used in the developing world, particularly when they don't have many psychiatrists or mental health practitioners available. And the idea is to take the tasks that have normally been assigned to professionally trained specialists like mental health clinicians or psychiatrists, and have non-specialist workers, people from the community who don't have that specialized training, provide those same services. And this involves potentially modifying the actual intervention so that it can be easily delivered by these non-trained workers, providing additional training to help the non-specialist workers be able to deliver the intervention, but also have the non-specialist workers supervised by a mental health clinician. And what we know from the developing world is that this has often been used to alleviate shortages in human resources. It's cost effective, and it's often a sustainable way to address achievement gap in low resource settings. And one way that I sort of framed my study is thinking about child welfare as a low resource setting where we don't have a lot of mental health staff available to really deliver these services. I also looked to implementation theory and frameworks to help me to figure out how could we best implement this in child welfare services. And so I relied heavily on the practical, robust implementation and sustainability model, which really identifies 4 main areas of things to think about when we want to implement something in an organization. And so the first thing is, what does the organization and the consumer think about this new intervention? What are the external environment factors that we have to think about, like policies and funding? And then what are the characteristics of the organization and the consumers that may get in the way or facilitate implementation? And then finally, how can we support sustainability? What training and what additional supports are going to be needed? So the first phase of my study really focused on listening to parents and providers in terms of how would we modify the intervention. And this took place over 7 Saturday meetings in 2014, where I recruited a group of parents with the lived experience of being involved in child welfare services, child welfare caseworkers, their supervisors, and a child welfare administrator, in addition to research staff. And so at every meeting, we provided breakfast and lunch, childcare for those who didn't have childcare available, transportation reimbursement, as well as a $20 gift card to pay for their time. And during these meetings, research staff facilitated discussions around how can we modify the intervention, what needs to be done differently, what needs to change, using task shifting in the PRISM framework. And during that process, we had observers take written field notes. And so this is an overall summary of some of the major themes that came up during these meetings. And I'm not going to go into a lot of detail with every single one, but I'll highlight a few. From the organization, one of the most important things was addressing the additional burden on frontline staff. For the consumer, we also had to think about their fears as facilitators, as mandated reporters, as well as concerns about literacy, that many parents may not have high literacy levels. And so we have to address that in the delivery of the intervention itself. We also know that, that many caseworkers also work in settings where there's low morale, and they may have limited skills as well. So based on some of these themes, we made a number of different modifications to the intervention. And so I'll highlight a few here. So first, we reduced the length because the caseworkers told us that 16 weeks was too long. We added mindfulness exercises, we added a strengths word board, and we added a section on old school meets new school, really to respond to what parents told us about what was important to them and some of the stressors that they were facing. We wanted to make sure in their training that parent advocates co-trained with the research staff when they were available, as well as include content on trauma-informed perspective and child development. And then we also encourage modifications within the organization. So for when caseworkers facilitated the intervention, we emphasized that those facilitators should have a reduction in their caseload, as well as receive incentives like CEUs or comp time to encourage them to keep delivering this service. So after this modification first phase, I thought, okay, I'm ready to deliver this intervention in the agencies that I had identified in the state that I live in. But I ran into a number of challenges. And I bring this out as important because implementation research can be very messy and challenging. In the state where I initially intended to do this intervention, I was told that I couldn't do it because task shifting was considered illegal by the regulatory body that oversaw child welfare services. So this resulted in me having to actually move my study to a different state where they had a different set of regulations and that allowed caseworkers to provide some of the strategies that were not allowed in another state. Another challenge was dealing with institutional review boards. These are those bodies that ensure that we're protecting human subjects and following federal guidelines. For those of you who are listening to this, who are researchers, dealing with one institutional review board can be very challenging, but I had to deal with 4. So that was another big challenge that I had to deal with. When I went to the new state, I was able to talk to some colleagues one of whom introduced me to her sorority sister, who happened to be the director of the Child Welfare Authority in that new state. And so that was how I was able to make those connections and to go through the second phase of the study. But midway through the study, that person left the organization. And so when I had to make changes to the study and go back to the Institutional Review Board, I had to basically reintroduce the study to a whole new set of people. So eventually I was able to actually deliver this in-home family preservation services. And the modified 4Rs and 2Ss for child welfare was delivered by caseworkers, none of whom had any advanced mental health training. And we delivered the groups to families receiving in-home family preservation services. And these families, they all had children who met diagnostic criteria for oppositional defiant disorder or conduct disorder, two of the most prevalent behavioral difficulties that we can encounter, and where their kids ranged in age initially from the ages of 7 to 11. And this was later changed in the middle of the study, and I'll talk about this later as we go further. And so we also collected data from caregivers who were receiving these services. So just a reminder, the whole purpose of this was really to increase access to effective services that address child behavior difficulties for those families that are involved in child welfare settings. So the second part of the study focused on, can we implement these services? Can we actually implement them? So more formally, the research questions focus on, was this new modified intervention feasible and acceptable? And the second question was, what factors impacted feasibility and acceptability? So the research staff, we provided training and supervision to the child welfare staff, and we held 3 group cohorts from 2015 to 2017. At the end of each cohort, we collected quantitative and qualitative data, and our outcomes focus primarily on feasibility and acceptability. And so we collected data from child welfare staff as well as the caregivers receiving services. So this is a summary of our outcomes. And if for those that are interested in more detail, I'm happy to provide some greater information. But when we look at the construct of feasibility, we identified it, defined it as family recruitment, fidelity ratings, child welfare staff feasibility ratings, and family attendance. And when I developed the study, we identified early on, like, what sort of metrics do we want to meet that says that this is a feasible study and we can move forward with it. So as you can see here, we met our quantitative benchmarks for family recruitment, for our fidelity ratings, and for our feasibility ratings, but not for family attendance. We wanted most of our families that attended to attend at least 80% of the sessions, and that didn't happen. And then we also looked at our qualitative data to, really understand the whys of why we got the information that we got. So with family recruitment, although we met our quantitative benchmarks, many of the staff and the families thought the recruitment criteria was too restrictive, both because of the age range of the children and the diagnostic criteria. And so this resulted in us modifying the study so that we could include a larger age range of children, as well as allow those families that didn't qualify for diagnostic criteria to at least participate as a non-research family. We learned from our child welfare staff that the fidelity ratings were really facilitated by a structured and detailed manual that bolstered their existing skills, as well as the support and consultation calls that provided by research staff. At the same time, there were some unplanned adjustments that were really linked to a lot of the crises and family needs that I spoke about before. We learned from the child welfare staff that they found it generally feasible. They were able to continue with their responsibilities and increase their own skill set. But despite all of the changes that we've made in the organization, it was still seen as an additional burden, which often resulted in late paperwork. Many talked about a role conflict where they were really used to this idea of mandating services and operating within a culture of compliance, where usually what you tell families is, if you don't do X, then something else will happen. But this intervention, the 4Rs and 2Ss, operated very differently. It operated from a strength-based perspective and really emphasized choice and family voice. And oftentimes this really child welfare workers had conflict with this. And so it was difficult for them to switch gears and switch hats. We had also initially thought that we could integrate some of these sessions into home visits. But when we finally got down to actually implementing it, we learned that trying to implement a full session in a home visit would be incredibly difficult, and the child welfare staff, if they were forced to do it, would actually just all up and quit. But instead, what we encouraged was them to try different parts of the intervention and see what worked. And this wouldn't necessarily be part of the study, but could definitely inform how we move forward with it. With family attendance, we did, as we expected, the logistical supports, the childcare, the transportation, the meals, these all helped in getting families to come, as well as the voluntary participation that the research staff emphasized, the peer support that they received from other families, and the non-judgmental attitude that was really emphasized in the group. That said, family attendance was really impacted by the various crises that they experienced. We had families where someone would get arrested, or their car would get impounded, or they got sick. There were lots of other stressors. And then we also heard, even though families knew the study was voluntary, many of the facilitators of the group were their own caseworkers. And so many of them felt obligated to attend. And this really speaks to that involuntary status and the complications of delivering interventions, particularly those strength-based, family-centered interventions in child welfare services. For acceptability, we looked at caregiver satisfaction, child welfare staff acceptability ratings and appropriateness ratings, as well as child welfare staff's attitude towards evidence-based practice. And so all of our quantitative metrics were met for these constructs. What the qualitative themes also let us know is that satisfaction was really linked to that welcoming, non-judgmental, comfortable group environment. However, caregivers weren't 100% satisfied. They really wanted to have separate time from their children to really talk about the stressors that they were undergoing. And then we also had some mixed perceptions about group size, the duration, as well as the power differential with having their facilitator, their caseworker also be their facilitator. With child welfare staff acceptability ratings, these were really linked to the fact that staff and families like the groups. They like the research support and the consultation, and that this intervention really filled a need for parenting program in their setting. However, the challenges with eligibility and recruitment really hindered acceptability. And there were also some mixed perceptions about the length of training. So what we also found with appropriateness is that while we met our metrics, the role confusion experienced by child welfare workers, as well as the difficulty with integrating the content into home visits, really kind of impacted the appropriateness ratings. And finally, qualitative data also indicated that these high ratings on attitudes towards evidence-based practices were linked to this idea that their practice was legitimized to stakeholders because they were delivering something that was effective and that added clinical tools to their toolbox, as well as improving their own awareness of evidence-based practices. So I'm going to remind folks again about our purpose. The whole purpose of this was to really increase access to effective services that address child behavior difficulties for families involved in the child welfare system. And our research questions focused on, can we implement effective services in child welfare services? And so what we get from our results is that it's somewhat feasible and acceptable based on what staff and caregivers are telling us. But there are still challenges with recruitment, attendance, eligibility, program length, role confusion, and this emphasis on compliance, culture of compliance, that remain challenges that we have to think about if we're going to consider implementing this intervention in the future. So based on these results, we've made some decisions in terms of next steps, in terms of these further revisions to the modified 4Rs and 2S for child welfare. So one of the most important things that we listen to with families is instead of having this intervention be placed in a setting where families have to have a child welfare case to receive the services, what if we placed it in settings where anybody could access it? That's non-stigmatizing, where you don't have a specific case-related access to, you don't need a specific child welfare case to access these services. And so we're thinking of implementing this now in family support centers or community-based organizations. We also are listening to staff and parents when they talked about diagnostic criteria. And so this next step study would really limit the number of the criteria to enter into the study. So we're just going to have families who are really struggling with managing their children as the main reason for them for coming into the study and receiving services. We're also going to add on to the intervention supports to address families' basic needs, as well as support caregivers specifically, because this was really important when we looked at family attendance. And then we also developed a train the trainer strategy so that supervisors could then also become trainers for caseworkers, and they could continue delivering this in the future well after the researchers left. And we also found a new name based on listening to parents and providers. So we're going to call this Families Supporting Families. And so I'm really happy to report that after I left and my research staff left, the staff that I worked with also then continued to deliver these groups on their own with no research funding and no research supervision. And in fact, they delivered 7 of these groups by themselves in local libraries. And then when the pandemic hit, online, serving a total of 41 families. And as we talked about, they didn't have any diagnostic or child welfare case eligibility criteria. And so I'm so excited to report this. We're working on a paper that will document these efforts. And unfortunately, the providers that were using this were not able to be in this presentation, but they're going to be my consultants as we continue this research enterprise in family support centers. So what have I learned from this process is one of the most important things is that tenacity matters, or as my mentor, Dr. McKay, has said, all's well that ends. Implementation research is messy and full of challenges. And so when one door slams shut, it's important to stay committed to creative problem solving. It's also important to get political capital. I mentioned before that I was able to move this study to a new state because one of my colleagues had a sorority sister in a position of power. So, and part of this also, this is how I got people to answer my calls. So it's really important to take advantage of any opportunity to meet and influence community stakeholders, especially agency and state administrators and community leaders. It's also important to recognize that turnover happens. So the partners that you work with at the beginning of the project, particularly in child welfare, may not remain through the project end. So it's important to have a plan early on to orient new stakeholders on a continual basis in order to sustain knowledge and motivation. It's also important to seek FaceTime. So one of the things that I think was really important in getting this study finished was being prepared to have multiple face-to-face conversations where I could nurture relationships, be transparent about my expectations, clarify everyone's different roles, as well as explore how to meet project needs. Another lesson learned is to really be clear about the benefits and the ask. So as you court potential stakeholders, having a one-pager that clearly identifies how this project benefits the organization or the consumer, as well as what your asks are for them, and be prepared to repeat these conversations throughout the life of the project, especially as stakeholders change. As I talked about earlier, particularly in work with child welfare services, is to be aware of the culture of compliance, which can sometimes put researchers in an ethical gray water, especially if there's concern that study participants may feel coerced. So be sure to have this conversation early on with your child welfare partners. It is also important, as we've learned from my experience, to understand the regulatory landscape. particularly how regulations change from state to state. Make sure you know, this means using your university's legal resources to identify those regulations up front and how they could influence your study, as well as get guidance on how to navigate them. Another lesson learned is that institutional review boards and implementation research are not always the best match. And so working with state systems also requires getting approvals through more than one IRB. And while getting approved through all of them, getting approved through all of them takes a lot of time. And so you have to plan for that well in advance, a year at most for your first year, just to get through all of these initial approvals. And be prepared to tweak your study as little as possible, because when you have to go back for modifications, that can delay your study's progress. Another lesson learned is sharing is caring. So to maintain these partnerships, I had to be willing to share control. And this meant sometimes ceding the rigor of the research design so that the implementation could feasibly reflect practice and I could keep my stakeholders engaged. So it's important to have a toolbox ready to go with different pragmatic methods and strategies as your project continues. And the final lesson is it does take a village. All of this work requires more than just one perspective and one lens. And I have really benefited not only from my mentors and research training, but also from the stakeholders with whom I've talked with, learned from, and listened to, who've really helped influence this work. And so I'm also happy to report that we were able to publish off of this research. And to date, we have 6 articles accepted or in press, with more to come. So thank you for listening to me. And I hope that this was helpful and for folks that are listening to this presentation.
Geetha, thank you so much for this presentation. As you mentioned, you and I had a little time for collaboration, but I'm still very excited about your outcomes. I think also you did pass the litmus test for listening and adjusting research, which is extremely important. So here's a question for you. Mm-hmm. I noticed that the program continued and benefited 41 families. Are you still receiving feedback and critique about the programs that have been implemented, or any little changes that child welfare workers are using with this program?
Yes. So the 2 main contacts, child welfare partners that are delivering this, they are going to be our co-authors in a paper that we are progressing right now that really talks to this issue of sustainability when the research money leaves, and how they were able to do it, what lessons that they learned, what challenges that they came across, but really just how amazingly they were able to do this with very little outside support, just support from their agencies. So definitely, it's I'll be hearing from them. And they're going to help inform me for the next grant that I write when we take this outside of child welfare services.
Oh, yeah, Lori.
I'm so sorry. I just want to step in very quickly and let our guests know that if they have a question, please feel free to put it into chat. Even if it's simply a comment that you want to share, we would love to know what you think. And on those lines, we have a survey for you. I've just put a link to that in the chat. So please, if you have to leave early, we completely understand, but we would love to know your feelings on this, how we can do things better. It's a very brief survey. So just if you can try to pull that link from the chat and take a quick survey, we would be grateful for your feedback. But I will let you get back to the important work of asking these great questions.
Thank you, Lori. Geetha, would you please respond to, there's a comment in the chat from Peter. He says, excellent idea to add concrete services. Kentucky added a flex payment of up to $1,500 to their family preservation and other prevention services, and found it to be very cost effective. Would you like to comment on that?
Yeah, I think hearing from families, both as a provider and as a researcher, especially those that are struggling with child welfare services, it's not just one stressor that they're dealing with. It's not just maltreatment. It's insecure housing, insecure food, as well as lots of different issues they have to navigate with different service systems. And for parents to really be able to have the mental space and the capacity to help their children through behavioral parent training, those basic needs really have to be met. If not first, at the very least concurrently. Because at the end of the day, if those basic needs aren't met, they get in the way of engagement and they really impact the ability of the parent to help adhere to these types of interventions. And behavioral parent training, I think, really asks a lot of parents to manage their children's behavior. And so the more we can support parents, ultimately, the more effective our outcomes are going to be in child welfare services. I think that link is really important.
Thank you. And my last question, and we'll turn it over to Mary as well as to the survey. I think you have a little psychic thing going on because it was going to be about the modified 4 R's and 2 S's. I found that to be very intriguing. So could you say more about that protocol and what revisions? I know this on the chart, but could you just talk to us more about those revisions that you see as necessary and forthcoming?
Right, I will. So I have recruited 4 community-based sites here in New York City. These are settlement houses. And for those of you who are social workers or been to social work school, any history of social work, these were settlement houses. We're helping newcomers, immigrants into the community, but there's still settlement houses actually all over the United States and several in New York City. And they provide a variety or an array of services for families within the neighborhood that, are designed to meet the needs from cradle to grave. So they have early childhood education, they have after school, they also have parenting services, they may have some mental health supports, but also services for the elderly. And because they're embedded in the neighborhood, they're really well known to families, and families tend to stay in them for years on end, tend to stay connected to them for years on end. And so because of that, they tend to have a better relationship and better credibility than I would assume child welfare services would be, and certainly mental health services. We're also going to expand on the use of peer support partners, or otherwise known as family advocates. So within the original model, when I was working with Dr. McKay, we had all sessions co-facilitated by a parent with the lived experience of raising a child with mental health difficulties and navigating the service system. And so I'm going to augment that role. So not only will we have peers or family advocates co-deliver this intervention with the existing staff at these community-based organizations, but we're also going to have the peers follow up with the parents individually. So contact them on multiple times on a weekly basis, help connect them with, help identify what their additional needs are, help connect them with services and resources in the community, maybe provide some education around child mental health issues, as well as help them to navigate through the different service systems. And the other goal would be to help them practice some of these skills and really just kind of be their coach and their cheerleader to keep parents going. So those are the main things. Right now, I'm vigorously working on this grant, and I hope to submit this to the National Institute of Health for funding. But I'm certainly really just committed to this idea of getting these interventions that can promote mental health, that can address mental health issues outside of mental health clinics, so that it can be easily accessible to families who might not otherwise access a mental health clinic or even child welfare services.
Perfect. So in a moment, we'll see a Vice Provost McKay come on screen. And as she's doing that, let me ask you, can you briefly remind us what was the original name? And then how do you feel about the new name?
Let me go back to this slide, the 4 R's and 2 S's.
Okay.
So I'll defer to, so the 4 R's and 2 S's, I will defer to Dr. McKay to add any additional information, but the name itself, what I understand, really came from the work that Dr. McKay had done with collaborative work with providers and parents to tailor the intervention, to translate the research literature into language that was really accessible. So the names, rules, responsibilities, relationships, respectful communication, stress, social support, these names all came from providers and parents, not from researchers, because we tend to have big words, and the more we get into it, the less sense that we tend to make. And so that was really important, I think, to make this a really accessible program. What I think about families supporting families is that I think it emphasizes this family support piece that and really centers on this idea that you're in a group with other families. Many of you may be struggling with different things, but you're also good at other things too. And also really emphasizing that peer support piece, that other parent who has been there, gone through this, and maybe has some insights to share. And so I really wanted to, I think my collaborators in child welfare and the families that I work with really like this idea that emphasizes we're working together, we're collaborating. It's not just being delivered to someone or impinged on someone, or that myself as a mental health clinician or provider is somehow a greater authority or knows more or knows everything more than other parents. And I think what I hope this emphasizes is that we share knowledge and we share different areas of expertise. And ultimately, we want to support each other.
So I'll also answer your question, Cynthia. Thank you for posing it, Geetha, to me as well. Those 4 R's and 2 S's were the words that families used to describe the key parts of family life that could help children be successful. And it was a really important merging of what the science said with family's voice. And so, but I think what's important is not to have an attachment to what we, in this context, named the program, as much as what emerges from next generation collaborations that will be helpful to kids and their families. I think that there's in the early work of EBPs, evidence-based practices, it was very centered in the researcher. And what we know is if these things are really going to align with what children and family need, there needs to be a collaborative process around how do you really integrate voice and choice on the family member, on the provider, as well as the science. And so that's the kind of, practices and the assumptions that our research groups have adopted. Yeah.
Thank you both.
So with that, Cynthia, any additional questions?
No, just a comment to say that this was great. I thoroughly enjoyed the information, and thank you so much for coming together, bringing this research to our region. So thank you so much.
Well, we appreciate you. So with that, let me close out our session. Let me thank both of our panelists, Geetha and Cynthia, for all your contributions that you've made here, but also in the rest of the work that you do. Thank you to this team, both Lori and Nicholas, for really pulling us together. Peter, you are our special guest. We are incredibly grateful for your leadership, the funding support, the collaboration, and what you do to spur the research field on to a better place and a more collaborative place. And so thank you. And let me thank our 3 groups of participants here, those that were live with us, those that have watched us on YouTube, and those of us that will watch us in the taped version of this seminar. Thank you so much.